I think it's a topic on retina. We've covered cornea, glaucoma, pediatric ophthalmology, and
Just give us 1 second. Can we have it up on the screen?
yes,
There we go.
we do. Yeah, we got it. Yeah. So, so there has been a paradigm shift in treatment of IRDs, at least the research into it. Well, I can't say that we have the treatment because some of these are not in India yet. So 2017, Luxturna for an RP65 mutation got approved. Unfortunately, Novartis had planned to do it, launched in India, and they pulled out of it for last year. So we now have phase 1 trials of gene therapy for other, Leber amaurosis, and the latest in the block is the nanoscope optogenetics. That seems to be very promising. So when in gene therapy, we talk about mutation-specific conditions, whereas when you talk about the cell therapy or optogenetics or Neuralink of Musk's Neuralink, these are all going to be mutation-independent approaches. So I'm just going to talk about the cell therapy and the landscape as we have today. And so a lot of the initial work was being done on using embryonic stem cells. These are obtained from the blastocyst. And so when Professor Shinya Yamanaka from Japan showed that you could take a peripheral blood sample and convert them into stem cells. They're called induced pluripotent stem cells. This sort of changed the world of stem cell research. And so most companies or academics that are doing research today mostly are working on AMD because we work on the retinal pigment epithelial cell as a first step before we go into photoreceptor diseases. So that's the outline. The average timeline that it takes for a proof of concept to go into the commercialization is between 15 and 20 years. So it's a lot of hard work, a lot of money, and a lot of effort, of course, that we have to sustain to get to that point. I'm going to spend the next few slides quickly on the journey of iStem. iStem is a startup based out of Bangalore. We are a stem cell-based company specifically for retinal diseases. We again chose to treat the first disease as geographic atrophy or dry AMD. It's an iPSC-derived RP suspension. So a lot of work happens in the background before we can even say that this is available for us. So what we do is, this is a 120-day protocol before the iPSC becomes a bunch of, RP cells, pigmented cells, in a dish. So once that's done, you have to have multiple animal studies. Most of our small animal studies were all done at OHSU in Portland, and we chose the RCS rat. The implantation here is a blind procedure. It's a transscleral delivery, unlike what we do in a human eye. And we had fairly good functional results and structural recovery. And so, sorry, I'm just going to skip this for the sake of time. So we've done, that's a summary of all the animal studies that we've done since 2017 to now. And once we had all of these, we have to show that the cells are safe, there are no tumors, toxicology studies. So incidentally, the toxicology studies were done at Dabur Research Foundation, here. And the next big problem to solve is you have all of these cells, you know that they are safe and they're efficacious in the animals. How do we deliver it in the human eye? So we collaborate with Singapore Eye Research Institute, to understand how these can be done. We sort of did multiple experiments to understand. So while surgically it is a subretinal delivery, there are problems associated with it because during the process of delivery, the cells that reflux can create an epiretinal membrane, and that is one of the biggest problems that this field is facing. So, so that's the regulatory roadmap. A lot of work that goes in, including your CMC or GMP manufacturing. A lot of work before we say that we're now ready to submit. So we submitted to the DCGI or the Indian regulator as for approval for IND, an investigation new drug approval for a phase 1 study. And we got an approval 1st of April last year. And so we started our first in human studies. These are phase 1 studies. Phase 1 studies are mostly for safety studies. We've got to show that these are safe in the human eye. So we had a dose escalation study of, it's 9 patients across 3 plus 3, 100, 200, and 300,000 cells. And then 3 participating sites, L.V. Prasad in Hyderabad, All India Institute RP Center, and in Delhi, and Sri Ganapati Netralaya in Jalna. So all of these are immune suppressed patients because we did for 3 months because these are allogenic suspensions, they're not autologous cells. And so several primary and secondary endpoints. So So these are a couple of the quick surgical videos. We've actually managed to, I would say that managed to deliver these cells with no major adverse events. And so that's the intraop OCT that shows that you actually have a successful delivery of the cells intraoperatively. That's another a video. So some bit of reflux that you see here is inevitable, and this is one of the biggest challenges. And I think we've sort of created an SOP where we've minimized this as much as possible. So these are the results. So the autofluorescence is our primary endpoint, and we've shown that, at least in some of our patients, there is a reduction in the area of the autofluorescence, GA area, and then you also show structural changes. So we could see that there are thickening of the outer retina, whether these are cells, whether it is a recovery of the photoreceptors, it's hard to say. So at some point, till we have a histopathological examination, it's not going to be possible to say that. We had a mild worsening of the epiretinal membrane in one eye, but we didn't need to do anything for that. So these are our vision results. So basically, it doesn't matter how much I show an autofluorescence or OCT. If there is no change in vision, it doesn't matter to a patient. So this is our first cohort, which has shown 10, 30, and 11 letter improvement. These patients have now been followed up for about 8 months, following the surgery. The second cohort showed a 15, 17, and a 7 letter improvement about 4 months following surgery. The third cohort has just been done. We don't have, it's too soon to say anything. So in summary, we've successfully completed phase 1 trials, no adverse events noted. What we've noted is a mild preretinal hemorrhage in almost every patient because the retina is very, very thin. This is expected. Mild worsening of ERM in one subject, an average of 14.9 letters of improvement. So we're now going to submit this to CDSCO and get approval for our phase 2 trials. We have some data on photoreceptors. I'm not going to go into this because that's a long way off. Quickly, the landscape of what else is happening in the world. So Lineage Therapeutics started off in Israel, is now incubated in the US. In fact, this product has been now bought over by Genentech. They had their first 3 cohorts, so they were sort of the leaders in the field, so they had the burden of being the first. So they showed a lot of problems with the surgical delivery. So what they did was to go to the 4th cohort and say that they would do it by an external approach. So this is a lot more complex. You do a pars plana entry, create a partial thickness sclerotomy, pass a band all around the eye until you see it under the macula through a wide angle. And once you see this, you have a foot pedal operated system where you can inject the cells. So they've shown good results with this, but now we're waiting for Genentech to take this forward and tell us what's happening. Luxa is Professor Sally Temple from New York. What they are using is an RPE layer from human cadaveric eyes. And they've just shown their first 9 patient data with really good results. So they've had improvement of about 21 letter improvement on an average. This is the suspension. There is the patch technology, the regenerative patch technology from California. They are using a Parline membrane and implanting this under the retina. And they've had good safety data. We don't know about the efficacy as yet. Dr. Kapil Bharti from National Eye Institute, he is using autologous cells on a patch. And I think they've done 1 or 2 patients and they've had no safety issues. And they are now actually going into a phase 1/2A clinical trial for this. This is as far as the landscape of GA, geographic atrophy. As for IRDs, is there any role in doing stem cells at all? It is there because even if the outer retina is gone, there's a lot of the inner retina that's sustained, and so it makes sense still to do it. So JSite is a company that is injecting intravitreally photoreceptor precursors. So this is, it's not mutation specific, does not require immune suppression, and they've actually, shown good results, and they've just launched their pivotal trial. We are yet to see the results of this. Blue Rock Therapeutics, actually this was a big launch in January in the JP Morgan Health Tech Meet. So they are a subsidiary of Bayer who have now started doing photoreceptor work. This is of course going to be a subretinal injection. And I think this is the only ones who are doing subretinal photoreceptors. So I think there's a lot of excitement about what this guy is going to say. So in conclusion, I think this is my personal thing, and that is the treatment for IRDs is not going to be a one-size-fits-all. I think it's going to be a continuum. Early diseases may be, it could be gene therapy. You have multiple mitochondrial boosters like Allegro and so on. Late disease could be cell therapy, optogenetics, Neuralink, and so on. So I do think the future for, it's quite exciting for, these IRDs. Thank you so much. That's where we are based at. There's an incubator in Bangalore called, C-Camp, and we are a lab within that. That's my team, and if you're in that part of India, please do come and visit us. Thank you so much.
Thank you very much, Dr. Rajani, for a fascinating talk and very good ray of hope for these IRDs.
Thank you, sir.
Very much. Can we have the...
For now, one injection. So I don't know. Nobody knows whether we need a repeat injection.
all right.